Hello everyone, I'm Dr. Shalini, specialized in obstetrics and gynecology, MS OBG and DNB OBG. Now we are going to discuss a topic on endometriosis. So what is endometriosis? Why we are more concerned with endometriosis? Endometriosis is a condition which is characterized by presence of endometrial tissue outside the uterus, like all around the pelvic viscera, like on the ovaries, on the surface of the uterus, or the surrounding tissues like uterosacral ligaments, and also sometimes in the distant viscera like lungs, heart can also occur. In endometriosis, in normal uterus, the endometrial lining gets sheds off in every month. This endometrial tissue should be present only inside the uterus. But in the endometriosis, this endometrial lining, due to some various reasons or various theories, it gets implanted outside the uterus, resulting in the formation of these endometriotic implants. Because since normally the menstruation sheds in the normal cycles, at the same time, at the same way, these outside endometriotic implants also become active, and they also shed some bloody tissues or endometrial tissues inside the outside this ectopic endometrial implants. This results in the formation of the scarring tissues and resulting in the formation of adhesions and resulting in the formation of these endometriotic implants. So in this way, the endometriosis occurs in certain individuals. And it is a problem of reproductive age group, that is about like 15 to 35 years of age group. So they generally come with complaints of pain or infertility, and in the process of diagnosis, we find this as endometriosis to these clients. PCOS is generally a problem of ovary. In multiple follicles are arranged all along the periphery of the ovary, giving a necklace-like pattern in the ultrasound picture. Generally, these are multiple small follicles of about 2 to 9 millimeters in diameter, and the ovaries are also enlarged in volume in polycystic ovarian morphology. And in endometriosis, it is not like many multiple small follicles. In fact, the number of follicles decreases, but it is characterized by presence of endometriotic cyst. Here we see some lacy pattern structures inside the ovarian cyst. Generally, it may be bilateral, and 2 or 3 multiple cysts, endometriotic cysts may be present. But in case of PCOS, what problem is, it results in impairment of the development of the mature follicle. As a result, follicle is not developing. As a result, follicle is not getting ruptured, and there is resulting in the anovulation and resulting in the infertility. Whereas in endometriosis, it is not the problem of anovulation, but it is the endometriotic cyst will decrease or impair the quality of the oocyte and resulting in infertility. Here, the number of follicles also decreases, in fact, in endometriosis. And the clinical features, symptoms, signs and symptoms are different in polycystic ovarian morphology and endometriosis. Therefore, these two are different entities, and the management also differs in these two clinical situations. The exact etiology is not known till now. The research is still going on, but there are certain theories and certain risk factors which make an individual prone to endometriosis. So what is causing this endometriosis? Each and every cycle, sometimes in the menstruation occurs, and this menstrual tissue may retrograde backwards, and they get deposited in the pouch of Douglas. That is the space behind the uterus. So it happens in normal individuals also. But why only some people are more prone for that? Because the decreased immune status of the individual and some genetic predisposition of the individual and some environmental factors and obesity, all these factors will cause endometriosis in these individuals. So generally this tissue, it should be cleared off by the immune system like phagocytosis, natural killer cells, which are the normal protective factors in an individual. But in endometriotic individuals, these factors will not function properly, or there is lack of this immune system, resulting in this implantation of endometriotic tissue outside the uterus, resulting in endometriosis. And genetic predisposition is also one of the factors. We don't know, in some individuals, it runs in families. There are clusters of individuals in the same family coming with the problems of endometriosis. And if you see mother-daughter relation, and also in siblings relation, if one sibling is affected, there are 6% times risk to see in the other sibling also. So there are genetic predisposition. It runs in the families. And some environmental factors, predisposition to some environmental pollutants, smoking, alcohol, which all will again further decrease the immune status and resulting in more predisposition to the endometriosis. And one more, early menarche, that is individual attaining menstruation at an early age, maybe like 11 years, 9 years, and very short frequent menstrual cycles history. In such cases also, because of this increased frequency between the menstrual cycles, what happens, each and every cycle the menstrual blood is getting deposited in the space behind the uterus, more prone for this endometriotic implants. So these are the risk factors: genetic predisposition and decreased immune status, and environmental factors, and obesity, and tall individuals also. In some research papers they also mentioned. So these are the risk factors for the endometriosis. Now we understood what is endometriosis, what is causing the endometriosis. So what happens because of this endometriosis? So the individual generally complains of severe dysmenorrhea. Dysmenorrhea means pain during the menstrual cycle. So what happens during this menstrual cycle, as the ectopic, that is the tissue outside the uterus, also responds to the hormones, they also produce some hemorrhagic collection and it gets deposited. It changes fibrin deposition and contractures, and ligament becomes pulled up. All this will result in severe dysmenorrhea. The patient comes with severe muscle cramps, lower abdominal cramps during menstruation. So this is the most important pain and important symptom of endometriosis. Generally, they come with complaints of pain before menstruation, and it continues during menstruation, and it even presents even after menstruation. So we call it as triple dysmenorrhea. So we have to differentiate dysmenorrhea from other types of normal dysmenorrhea also by this classical features of present before menstruation, during menstruation, and even after menstruation. And this is one of the symptoms. The second symptom is they present with chronic pelvic pain. Just they always complains of some low backache. They say there is continuous backache, ma'am, continuously present before the menstruation or also in between the menstrual cycles. In such cases, we have to evaluate, we have to do scans to rule out this endometriosis. Now, the upcoming symptom is now infertility, because the clients or the recent, all the people wanting for the career, they delay their marriage age, they delay their fertility. So they come in generally 30s and they come with the problems of infertility. In 30% of the clients who are coming for fertility treatment are diagnosed with endometriosis. So dysmenorrhea, chronic pelvic pain, infertility, and one more thing, they also present with symptoms of dyschezia. Means even during defecation, they also have problem. This is because of involvement of the intestines. And they also complain of dysuria, that is pain during urination. This occurs when endometriosis involves a bladder or ureter, that is the urinary organs. So when they involve this, they also complain of dysuria. So in a summary, taking into account where it gets involved, it results in severe dysmenorrhea, that is pain during menstruation, or chronic backache. They complain of backache continuously even between the menstrual cycles. They also come with complaints of infertility when they seek treatment for fertility, or pain during urination, or pain during defecation. So the summary is it causes pain. That is the main problem of endometriosis. First, after the symptoms, after the patient complains of the symptoms, so to diagnose it, we do a examination. In generally married women, we do a transvaginal examination. That is, we examine from down and see for any pain, patient complaining of pain during the process of examination. Or sometimes we also see the mobility is restricted. Generally, the uterus and the surrounding structures are freely mobile. In such cases, in endometriotic cases, because of adhesions or because of fibrotic changes in the structures, the mobility is restricted. So if we see that the mobility is restricted and the patient complaining of pain during the process of examination, we can also come to a conclusion it might be a case of endometriosis. Now, still we are in dilemma whether it is endometriosis or not. So now for the confirmation, we do an ultrasound. In ultrasound, we look for the uterus and the ovaries and also the surrounding fallopian tubes. Ovaries, generally we see this endometriotic cyst. I told you before, na, endometriotic cyst, that we call it as endometriomas. So they will be present in the ultrasound picture. And ovaries are generally seen beside the uterus, and they can also be mobile. But in endometriosis, they are adherent to the uterus and they can be seen just lateral to the uterus. And they also complains of pain while doing even the ultrasound also. So decreased mobility of the structures and pain during the procedure, presence of endometriotic cyst, and sometimes there may be fallopian tubes gets enlarged and resulting in the hydrosalpinx also. So in all these features in ultrasound will tell us this may be a case of endometriosis. But again, whether it is a mild or moderate or severe, we can't judge just seeing the ultrasound picture. So for confirmatory, we do the laparoscopy. Laparoscopy is like, it is a minimally invasive surgery. We keep a telescope through which we see the organs, and these are projected on the TV screen. So in here, laparoscopy, we see some black or bluish powder burn appearances on the surface of the uterus, on the surface of the ovaries, and also on the surface surrounding the structures, the peritoneum, that is the lining covering all these pelvic viscera. So if it involves the uterosacral ligaments, that is the more important structures surrounding the uterus, and we also feel the presence of this nodularity in this uterosacral ligaments, and sometimes the space is almost covered. Generally, we should see the complete uterus, ovaries, and fallopian tubes. But in endometriosis, because of this endometriotic implants, there will be complete adhesions. Sometimes there may not be accessible to reach the uterus also. So all these features, that is endometriotic implants, either it is pinkish or it is white color or it is dark brown, all these deposits over the surface of this uterus and the ovaries and the fallopian tubes, and any adhesions between the uterus and the ovaries, and this distorted anatomy between the tubes and ovaries, this all will suggest that it is a case of laparoscopy. And also we can diagnose it is mild or moderate or severe by laparoscopy. So thus from examination and ultrasound pictures and from laparoscopy, we can diagnose that it's a case of endometriosis. Women who are seeking treatment for fertility when they are diagnosed as endometriosis, so they will be managed accordingly, like either medical management, that is by giving drugs, that is oral medications, for a couple of like 3 to 6 months, or they can be treated with surgical management in severe endometriosis to decrease the burden of the disease. So whatever, we have to ultimately decrease the burden to the patient. And we have to restore the anatomy of the tubo-ovarian relationship, because for fertilization to occur, for pregnancy to get achieved, there should be proper tubo-ovarian relationship. So now the pregnancy has occurred, that is the client has attained the pregnancy. Pregnancy itself is a good factor for endometriosis, because in pregnancy there is no menstruation, therefore there is no endometriotic aggressive increase in the nature of the endometriosis. So after pregnancy, what happens again? After pregnancy, since again the patient regains her menstrual cycle, the problem of endometriosis may recur, but not to the previous extent. So again, she may complain of pain or dysmenorrhea, pain during menstruation. And in such cases, as she has completed her family, if she completed, we can advise hormonal therapy for a period of 6 months or more. If suppose she doesn't complete her family and she wants a pregnancy again, you can give the treatment for 3 to 6 months and again plan for pregnancy. So the summary is like, even after pregnancy, the chances of endometriosis can recur, but not to the previous extent. And as age advances, as a patient reaches perimenopause or menopause, that is stopping of the menstruation, even the endometriosis, the problem will also decrease. Endometriosis is a chronic, progressive, debilitating disease. Once it is there, it progresses eventually during the menstrual cycles. So once a patient reaches menopause, maybe at that time this problem may be solved. But what happens? What to do all these years? So first thing is we have to diagnose it's a case of endometriosis and treat her with the medical management. And if required, maybe surgery has to be done to decrease the disease burden. But we can prevent or we can decrease the disease intensity by just changing some lifestyle modifications like decreasing weight, improving good antioxidant-rich vegetables and fruits, and workup. Like physical activity, they all will decrease the menstruation process, or it will result in the regular menstrual cycles, not many heavy or low. So thus we can decrease the burden of the disease. And then we can go for the medical or surgical management.